Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be doing the quick revision of this very important topic, hypercalcemia. In the next subsequent section, I'll be doing the quick revision of the hypocalcemia. So if you take the calcium homeostasis, the level of the calcium in our body is being maintained by parathyroid hormone, which will increase the calcium. Then active form of vitamin D, that is calcitriol, which will also increase the calcium. Then we have calcitonin, which is produced by parafollicular cells or C cells, which will reduce the calcium. So the first two will increase the calcium and the next one will decrease the calcium. So if you take the parathyroid hormone, how it will increase the calcium? It will increase the bone resorption, thereby increasing the calcium, and it will increase the calcium reabsorption from the kidney, and thereby it increases the calcium. Then if you take vitamin D, it increases the calcium by increasing the absorption from the gastrointestinal tract. So the vitamin D, it increases the gastrointestinal calcium absorption. So these are the hormones. And what about the calcitonin? It will reduce the calcium by sending the calcium from the plasma into the bone. So these are the three important hormones which play an important role in calcium homeostasis. Now, what are the various causes of the hypercalcemia? The various causes of hypercalcemia include, number one, primary hyperparathyroidism. Right? Primary hyperparathyroidism. So this is number one. Then followed by that, we have certain malignancies also. What are those malignancies? Like pheochromocytoma. So these pheochromocytomas, they release parathormone related protein, and that will increase the calcium. Then we have some granulomatous diseases also. These granulomatous diseases that includes like sarcoidosis, they increase the calcium by producing the vitamin D. Then we have familial hypocalciuric hypercalcemia, where you have calcium sensing receptor mutation, and that will result in the hypercalcemia. I'll be discussing that in detail. Then hyperthyroidism, that will be causing hypercalcemia, and then followed by that, the milk alkali syndrome. So these are the various causes for the hypercalcemia. Now, how do you differentiate one from the other? That is purely based on the parathyroid hormone. So in case of primary hyperparathyroidism, there is increase in parathormone level, whereas in certain malignancies and vitamin D excess, where the calcium levels are high, the parathormone levels will be reduced, because the trigger for parathormone release is calcium. When there is hypocalcemia, the parathormone level increases. When there is hypercalcemia, parathormone level decreases. Right? Except for your primary hyperparathyroidism. In primary hyperparathyroidism, the malignancy itself is in the parathyroid gland, that increases the parathyroid hormone, and that increases the calcium. Now, the first important is the familial hypocalciuric hypercalcemia. So in case of the familial hypocalciuric hypercalcemia, it is an inherited disorder, that is autosomal dominant type of inheritance, and it is familial hypocalciuric. That means there will be low urine calcium. Right? That means there will be low urine calcium. And why is this due to? This is due to calcium sensing receptor gene mutation. Right? This is due to calcium sensing receptor gene mutation. Now, what exactly is this calcium sensing receptor? See, these calcium sensing receptors, they are distributed across the parathyroid gland, and they are distributed across the kidney. Okay, they are distributed across the parathyroid gland and as well as kidney. So in parathyroids, you have the calcium sensing receptors. They sense the extracellular calcium and suppress the parathyroid hormone secretion if calcium levels are high. That is what the calcium sensing receptors does. And not only that, even in the kidney, you have the calcium sensing receptors. Where do you have it in the kidney? You have it in the thick ascending limb of loop of Henle. And you also have this in the distal convoluted tubule, right? So the calcium sensing receptors which are present at the level of the kidney, what they do is they reduce the calcium reabsorption when serum calcium is high, right? They reduce the calcium reabsorption when the serum calcium is high. So at the level of parathyroid gland, it helps in parathyroid hormone secretion. And at the level of the kidney, the calcium sensing receptors, they help in the calcium reabsorption depending upon the serum calcium level. That is the role of calcium sensing receptor. Whereas in case of familial hypocalciuric hypercalcemia, the calcium sensing receptors, they have reduced sensitivity. Right? Calcium sensing receptors, they have reduced sensitivity to extracellular calcium. Right? They have reduced sensitivity to the extracellular calcium. Now, what these calcium sensing receptors think in case of familial hypocalciuric hypercalcemia is, it thinks that the serum calcium levels are low. Right? It thinks that the serum calcium levels are low then compared to normal. Actually, there are like normal calcium in that individual. But here, there is mutation of these calcium sensing receptors and they think that the serum calcium level is low. And parathyroid gland does not suppress the parathormone appropriately. Okay? So, now because there is the defect in the calcium sensing receptor, what happens is the parathyroid hormone or parathyroid gland does not suppress the parathormone appropriately. So, there will be mild elevation of the parathyroid hormone or inappropriately normal parathyroid hormone despite hypercalcemia. Right? So, even though there is hypercalcemia, there is mild elevation of the parathyroid hormone. The same way, even in the kidney also. In kidneys, there will be decreased calcium sensing receptor signaling. So, because there is decreased calcium sensing receptor signaling, there will be increased calcium reabsorption at the level of renal tubules. Right? There will be increased calcium reabsorption at the level of renal tubules. Thereby, what will happen to the urinary calcium? There will be low urinary calcium. So, this is what is called familial hypocalciuric hypercalcemia. So, the defect is mainly at the level of the calcium sensing receptors. Now, in case of familial hypocalciuric hypercalcemia, if you see the various parameters, the serum calcium levels are mildly elevated because there is increased calcium absorption at the level of the kidney. And parathyroid hormone, either it is normal or it is mildly elevated. And the serum phosphate levels, either they are normal or mildly elevated. And what about the urinary calcium? That will be reduced. And magnesium, there is mild elevation of the magnesium. So, this is about the familial hypocalciuric hypercalcemia. Then we were discussing about the parathormone related polypeptide. So, where the substance which is being released, it mimics the parathyroid hormone. So, that we call it as parathyroid hormone related polypeptide. They are the one which can increase the calcium. So, you have some solid tumors, like for example, the pheochromocytoma. They produce parathyroid hormone related peptide. And this parathyroid hormone related peptide, it is the one which will mimic the parathyroid hormone and it will increase the calcium and decrease the phosphate. And once there is increase in calcium, what will happen to your parathyroid hormone levels? Parathyroid hormone levels are suppressed, but the calcium levels are being elevated. So, this is about the parathyroid hormone related peptide. Now, let me discuss the various causes of hypercalcemia and their mechanism also. One of the very important cause that we were discussing was primary hyperparathyroidism. So, in primary hyperparathyroidism, there will be increased bone resorption, there will be increased renal absorption of the calcium, and there will be increase in the synthesis of calcitriol, and that will increase the increased calcium absorption across the gut as well. So, that is what you observe in case of primary hyperparathyroidism. Whereas you take in case of tertiary hyperparathyroidism, there also you will have hypercalcemia. What is the mechanism? So, here there is autonomous parathyroid hormone secretion after chronic secondary hyperparathyroidism. So, what is tertiary hyperparathyroidism? So, once you correct hypocalcemia in case of secondary hyperparathyroidism, parathormone secretion should reduce. But in spite of correcting the hypocalcemia in case of secondary hyperparathyroidism, parathormone levels, they are still elevated. That is called tertiary hyperparathyroidism and commonly observed in the scenario of chronic kidney disease. And just now we were discussing about familial hypocalciuric hypercalcemia where you have defect in calcium sensing receptor. And then we were discussing about parathormone related polypeptide which mimics parathyroid hormone, and this is being produced by the small cell carcinoma of the lung, and it is also produced by renal cell carcinoma, and it is also produced by the pheochromocytoma as well. And we have some malignancies which undergo bone metastasis like breast carcinoma and as well as myeloma. They metastasize to the bone, and they will cause direct osteolysis, and that will release the calcium from the bone, resulting in the hypercalcemia. Then followed by that, we have vitamin D intoxication. See, vitamin D intoxication, there will be excess vitamin D, there will be excess calcium absorption from the GIT, and that will result in the hypercalcemia. Then you have granulomatous diseases. These granulomatous diseases include sarcoidosis and as well as the tuberculosis. So in case of these granulomatous diseases, there will be activated macrophages. This will increase 1-alpha hydroxylase activity. This will increase the calcitriol synthesis, and this will increase the gut calcium absorption. That is a mechanism of the granulomatous diseases that will cause hypercalcemia. Then we have thyrotoxicosis. In thyrotoxicosis, there is increased bone turnover due to excess thyroid hormone, which will be causing hypercalcemia. Then we have adrenal insufficiency, where the individual will be having hemoconcentration and increased bone resorption due to glucocorticoid deficiency. Followed by that, immobilization is also the one which can cause hypercalcemia. And if you see the mechanism, in case of immobilization, especially in high bone turnover states, there will be like, whenever there is immobilization, there is decreased mechanical stress. And in a state of decreased mechanical stress, there is increased osteoclastic activity, there is increased osteoclastic bone resorption, resulting in the hypercalcemia. Then not only this, we have some medications also which will be causing hypercalcemia. For example, like thiazides. Thiazides, what they do? They decrease the urinary calcium excretion by enhancing the calcium absorption at the level of distal tubules, causing hypercalcemia. Then we have lithium. So lithium, it increases the parathyroid hormone secretion by altering the calcium sensing receptor sensitivity. Then followed by that, we have milk alkali syndrome. Milk alkali syndrome, you have the excess calcium and absorbable alkali intake. The excess calcium and absorbable alkali intake is the one which will be causing hypercalcemia and metabolic alkalosis. Acromegaly, where there is excess growth hormone in adults. Acromegaly, there is increased bone turnover from excess growth hormone and then IGF-1. So more and more growth hormone or more and more IGF-1, there will be increase in bone turnover, resulting in hypercalcemia. And pheochromocytoma, this will produce parathormone-related polypeptide, which mimics the parathyroid hormone, and that will increase the calcium level. Next is dehydration. In case of dehydration, there will be hemoconcentration, there will be decrease in the GFR, and this will reduce the calcium excretion, and that will result in the hypercalcemia. So these are all the various causes of hypercalcemia and their respective mechanisms. Now, if you take the clinical features in case of the hypercalcemia, if it is like mild hypercalcemia, the individual may be asymptomatic. But if the calcium levels which have been elevated is around 11 to 12 milligrams per deciliter, the individual can have the contraction of the gastrointestinal sphincters causing constipation. There will be nephrolithiasis causing loin pain. There will be stimulation of the parietal cells resulting in peptic ulcer disease causing abdominal pain. And there will also be calcium absorption within the blood vessels causing the pseudo-hypertension. So that will be the features that you will have when the calcium levels are in between 11 to 12 milligrams per deciliter. And when the calcium levels are in between 13 to 15 milligrams per deciliter, in this scenario of the calcium levels in between 13 to 15 milligrams per deciliter, the calcium can cross the blood-brain barrier. And when calcium crosses the blood-brain barrier, it goes and accumulates within the cerebral neurons, resulting in psychosis, resulting in depression, resulting in basal ganglia calcification causing secondary Parkinsonism, and there will be also bony pain. And when calcium levels are more than 15 milligrams per deciliter, that is the point when the individual can have a systolic arrest. Right? That is the point when the individual will have systolic arrest. So, neuropsychiatric symptoms, gastrointestinal issues in the form of constipation, dehydration, then the AV block can occur in severe cases. Then if you take the workup in patients with hypercalcemia, first and foremost, definitely calcium levels are being elevated, and you need to check the levels of the parathyroid hormone. You also need to check the levels of the vitamin D, and you also need to check the levels of the parathyroid hormone related polypeptide. Okay. So it is your parathyroid hormone which is a key to distinguish parathyroid versus non-parathyroid causes. In parathyroid causes, parathormone levels are elevated, whereas non-parathyroid causes causing hypercalcemia, the parathyroid hormone levels are reduced. And whenever you are calculating the calcium, you need to calculate the corrected calcium. What do you mean by the word corrected calcium? See, out of the entire calcium which is being present, 40% of the calcium, it is bound to albumin, right? And 50% of the calcium, it is the ionic calcium. it is like free calcium. It is not bound to any other substance. Whereas 10% of the calcium, it is bound to the anions like the phosphate. So what is important for us is the corrected calcium. What do you mean by that? Now, if the albumin levels are reduced, right? If the albumin levels are reduced, in a scenario of reduced albumin levels, what will happen to your total calcium level? The total calcium levels will be reduced because your bound form is reduced. Whereas your ionic form, that is the free form, does not change. That will remain constant. Okay? When the albumin levels are reduced, the bound form is reduced, so the total calcium is reduced. So that is the reason why we need to calculate the corrected calcium. Now, what is the formula for the corrected calcium? So corrected calcium is equal to measured calcium plus 0.8 multiplied by 4 minus albumin. And how much is the normal albumin level? The normal albumin level is 4 grams per deciliter. If albumin level is low than compared to normal, the corrected calcium will be higher than compared to that of the measured calcium. Let me just give you an example. Let us just assume the measured calcium is like 8.5 and the albumin of the individual is 2.5. Let me just incorporate these values in the formula. What is the formula? That is the measured calcium plus 0.8 multiplied by 4 minus albumin. That is the formula. So corrected calcium is equal to 8.5 plus 0.8 multiplied by 4 minus 2.5. What is this 2.5? It is the serum albumin of the patient. So what is the corrected calcium you get? That is 9.7. So if you see here, the patient calcium is actually normal after the correction. Right? The patient calcium is normal after the correction. So whenever there is hypoalbuminemia in a given patient, you need to calculate the corrected calcium. The calcium which is not given is not a true calcium if there is hypoalbuminemia in the individual. Then how do you treat these patients with the hypercalcemia? The first line treatment is IV fluids that will be causing dilution effect of the calcium. Then you need to give bisphosphonates. Bisphosphonates are given mainly if the hypercalcemia is due to hyperparathyroidism. Then we have many other molecules like calcitonin nasal spray. This will reduce the calcium. Then we have denosumab, right, which is a monoclonal antibody which will reduce the osteoclastic activity. Then next is steroids, and in refractory cases you need to do dialysis. And among the bisphosphonates, like bisphosphonates, what we have is like zoledronic acid, or you have ibandronate. So, and whenever you're giving these IV fluids, which particular IV fluid that you need to give? That is 0.9% sodium chloride has to be given. This 0.9% sodium chloride, this expands the intravascular volume, this increases the GFR, and it increases the renal calcium excretion. So this IV fluid that is normal saline, this is considered to be the first step in severe hypercalcemia, and it will correct the dehydration. Then we have loop diuretics like furosemide. What this furosemide will do is, furosemide will inhibit NKCC2 in thick ascending limb, and this will reduce the positive voltage, and this will reduce the passive calcium reabsorption. But please remember, you need to give this loop diuretic only after hydration. After giving IV fluids, then you give this particular loop diuretic. And in the case of hypercalcemia, you should avoid thiazides, because thiazides itself, they can cause the hypercalcemia. Then the another important molecule is calcitonin nasal spray. What this will do? This will directly inhibit the osteoclastic activity, and it will decrease the bone resorption, and it will increase the calcium excretion as well. That is how the calcitonin level, or the calcitonin, will maintain the calcium. And this calcitonin, it has rapid onset of action within 4 to 6 hours. Within 4 to 6 hours, the action of the calcitonin can be there. The other drug, as I was saying you, bisphosphonate, that is zoledronic acid, and as well as palmitonate. What is the mechanism of action of this particular drugs is, they bind hydroxyapatite in the bone, and it inhibits the osteoclast mediated bone resorption. And this bisphosphonates, they are considered as the mainstay of treatment for malignancy related hypercalcemia. But the onset of action, it is not like calcitonin where you have a rapid onset. It has a slow onset of action. It will take almost 24 to 48 hours. Mainly in case of primary hyperparathyroidism, bisphosphonates are considered as the drug of choice. Then we have monoclonal antibodies, that is denosumab. And denosumab, it is the one which will act against the rank ligand. Thereby it will prevent the osteoclast differentiation and as well as activity. So this denosumab, it is the alternative to bisphosphonate, especially in renal failure. So this is about monoclonal antibody, that is denosumab. And among the glucocorticoids, it is prednisolone. What this prednisolone does is, prednisolone, it decreases 1-alpha hydroxylase in the macrophages, and thereby it decreases the calcitriol production. Thereby, it decreases the calcium absorption. That is what the prednisolone does. So prednisolone basically decreases the 1-alpha hydroxylase, and thereby it decreases the calcium absorption. So this prednisolone is mainly useful in a scenario of vitamin D toxicity, useful in case of the sarcoidosis and as well as the other granulomatous diseases. Then we have like dialysis, where we do a low calcium bath. So here, in case of dialysis, direct removal of the calcium from the plasma. But in which scenarios we do dialysis is, mainly this dialysis is reserved for the severe or refractory hypercalcemia or the renal failure. That is when you need to do dialysis. Then we have a cinacalcet. The cinacalcet is the one which mimics or which activates the calcium sensing receptor in parathyroid gland, and it decreases the parathyroid hormone secretion, right? So this particular cinacalcet, it is used in primary hyperparathyroidism when surgery is not possible, and in case of parathyroid carcinoma also, this cinacalcet is useful, which acts as a calcimimetic which stimulates the calcium sensing receptor and decreases the parathyroid hormone secretion. Then we have one of the rarely used molecule, that is gallium nitrate. What it does, it inhibits the osteoclastic activity. Why it is being rarely used? Because of the nephrotoxicity. That is the reason why it is of limited use. So this is what is the treatment of the hyperparathyroidism. So IV fluids, like the first line, whereas in primary hyperparathyroidism, bisphosphonates, they are the first line molecules. And the individual not tolerating the bisphosphonates, the alternative molecule that you have is denosumab. And in vitamin D toxicity causing hypercalcemia, like glucocorticoids have to be given. And in severe and refractory cases, dialysis has to be done. And cinacalcet is another alternative molecule that can be given in case of primary hyperparathyroidism. So this completes the quick discussion of the causes of hypercalcemia, the workup of hypercalcemia, and then treatment of the hypercalcemia. Thank you very much.